Namaskar, ma'am. And good evening, all. Welcome you all for this webinar on role of neuroprotective agents in patients with vascular and non-vascular cognitive decline. And the speaker, Dr. Professor S.R. Chandra, ma'am, is well known across the country. Ma'am has a lot of credentials. Ma'am worked as a HOD in Nimhans.
Not audible. No?
Neuro department and presently working in Trivandrum. Not, am I audible now, madam?
Yes.
Yes. It's my pleasure introducing Professor S.R. Chandra, ma'am, who was ex-HOD of Nimhans Neurology Department. Now, presently, ma'am is executing her work from Trivandrum. I welcome Professor S.R. Chandra for this webinar. It's one of the most privileged to have ma'am on today's program, and ma'am will get into the program now. Over to you, ma'am. In fact, ma'am's credentials are plenty. That itself runs for 1 hour. So much so, and ma'am has got more than 200 papers to her credit. With this very brief note, and we are humbled with your presence, ma'am. We look for your deliberations. Over to you, ma'am.
I thank Shri Douglas sir and Jyoti Kumar sir for this opportunity. And thank you very much. I will just go through this use of these neuroprotective agents, which we all know that they are called as smart drugs. So we will start with a brief introduction of what happens in various situations where these are used. And I have made it very brief for a 1 hour session. So we'll see what is normal aging, what is pathological aging, what is cognitive reserve, what are the normal repair mechanisms, what can be sustained and mechanisms to sustain, and the philosophy of living. That is the plan in which I want to approach this topic. So aging, as we know, is a phenomenon which represents a mixture of cellular and systemic physiological changes. Aging is physiological, it is not pathological, intrinsic to the species and the environmental factors which interact with these processes. And this aging starts probably at conception itself or at birth. But at one particular phase, the decline in function will start, and that ends in senescence. And one Purusha year is approximately 120 years. So up to 120 years, it is possible to function independently and effectively, provided the environmental influences are favorable. So how this aging and degeneration takes place? By many mechanisms. One is telomere shortening. Telomere in the chromosome shortens, and that if we can check, we can see how that particular person is going to age. Will be okay till 120 years or much lesser than that. This can be easily studied and it can be analyzed in Nimhans itself. And then random damage due to multiple problems in the environment, exposure to toxins, radiation, and diseases. And then somatic mutations. Natural mutation. What is a mutation? It's a stable, heritable change in the gene. So apart from the telomere shortening, damage occurring due to various factors in the environment, and mutation taking place in our genes, and error catastrophe. What is that error catastrophe? In genetic code, normally the mechanism should be facilitatory, but sometimes the gene code will go in a way that it produces catastrophic results in the genetic code. That is called error catastrophe. And pleiotropic antagonism. That is, instead of promoting growth, it will promote apoptosis. So that is antagonism. And growth inhibitors and suicide genes. These are also there, but they are in a particular proportion. When they become beyond the balancing range, aging will proceed faster than what is expected in normal aging. So these are primary mechanisms. What are the secondary mechanisms? Infections, environmental factors like radiation, autoimmune disorders, hormonal and nutritional factors, neoplasms, and metabolic disorders. So these are secondary mechanisms. So what is this apoptosis? Apoptosis is programmed cell death. So every cell has got a fixed doubling time. After that, the cell will die. And nuclear condensation, blubbing, and chromatin shrinkage takes place in apoptosis. And this way, about 50 to 70 billion cells die every day. Only thing we are not aware because it is repaired and replaced. And we have got death ligands, death receptors, which initiate caspase, and that caspase is the apoptotic enzyme. So death ligands and death receptors are put into negative catabolic mode using the enzyme, that is caspase, initiator caspase and effector caspase. And this influences mitochondria. Mitochondria is the powerhouse of every cell, which is present everywhere other than the mature RBC. And without that, we cannot work. So mitochondria, cytochrome C and DNA damage will be initiated by these death ligands and death receptors and resulting in cell death. And excess caspase will result in degeneration. And defective caspase results in autoimmunity and cancers. So these are the basic mechanisms in the various diseases in which neuroprotective agents are useful. And what is neuroprotection? Neuroprotection is the mechanism which prevents neuronal damage by intervening in and inhibiting the pathogenetic cascade. Briefly, I have introduced the pathomechanism. Each mechanism is a textbook by itself. So only the skeletal thing is given, skeletal information is given. Interested people can go ahead reading all those things. So this pathogenetic cascade should be inhibited by the neuroprotective agent, the caspase mediated apoptosis. And neuroprotection is an effect that may result in salvage, recovery, regeneration of the nervous system, its cell structure and function, and other systems also, because it is a neurology based session. I am telling about the nervous system. And the agent should limit nerve death after a CNS injury. These agents, supposing there is a road accident, that should limit nerve death after the injury of any nature, road accident or infective injury or autoimmune injury, and protect the central nervous system from premature apoptosis. Normal apoptosis will result in the demise of the person approximately around 120 years. But premature apoptosis should be prevented. So these are the main functions of neuroprotective agents. And what is cognition? Where we use these agents? Cognition is defined as the highest level of intellectual function available for formal testing methods, and this includes executive function. Executive means setting a goal and achieving, learning new things, visual and verbal analysis. And its foundation lies in 108 billion nerve cells, which are capable of 10 to the power of 2008, 3 and so many zeros of interconnections, which is higher than the total atoms in the universe. So they are kept folded and tinily interwoven that the whole universe is accommodated inside our skull through these synapses. And we have gone through the era of diagram makers, trying to study the function of these nerve cells. There was an era that when we have a Braca and Wernicke, they thought by analyzing the patients after they died, that somebody who cannot speak expressively had a Braca's area, somebody who cannot comprehend had a Wernicke's area. But later, people who presented with Wernicke's aphasia and Braca's aphasia did not have lesions in those areas. So initially is the era of diagram makers who drew diagrams in the brain and compartmentalized its function. But later, compartmentalization phenomena was not working in all cases. So the era of lumbers, they lumped the whole functions to the whole brain. So this is a very curious organ, very difficult to understand. And Gray's Anatomy 1973 edition states, ancient civilizations of the world know very little about neurology. So you can imagine this Bible of anatomy making a statement like this. But Charaka Samhitya speaks about nervous system in the BCs. So we should salute the wisdom of our ancient system, which we forgot because of 3 to 4 decades or 3 to 4 centuries of slavery. And it is the duty of all of us to go back to our ancient wisdom. And this abstract cognition was the essence of ancient Indian spirituality and medicine. So aging and cognition, that is 33 stem cells. Nervous system developed from 33 stem cells. All of us know that each organ developed from primordial cells called stem cells. And 33 stem cells make the CNS by signaling to each other, wiring, perceiving, connecting, inhibiting, completing, and interacting. Inhibiting is called pruning. Unwanted wiring is pruned. That is the role of this music and talat, pat, and all those things. They help smooth wiring. Supposing the child is brought up in a very nasty, noisy, quarrelsome environment, it has been proved that many of them wire wrongly, and seizures, schizophrenia, these disorders are more in the developing period when this wiring becomes disordered signaling. So those group of disorders are called signaling disorders. So by the time of 65 to 80 years, mild insomnia, retrieval defect, and inability to attend to multiple stimuli, all this happens, that is normal. And in normal age-related cognitive change, vocabulary and learned information remains unaltered, although performance time may be prolonged. They may be taking more time, but everything is functionally retained. That is normal aging. A normal adult brain weighs about 1,230 to 1,275 grams in the female, a little more in the males. But now it is becoming equal because females are also equally using the brain as the males. And so this is a adapter mechanism based on use. So now it is almost the gender differences is getting annulled. And by the age of 80, there are approximately 20% decrease in the blood flow to the brain and about 233 grams of brain weight loss. So when a patient claims memory problem but not significant to be called dementia, we have to see whether it is just a subjective cognitive decline, normal aging, or abnormal aging, because those situations, we have to start prescribing what we think will be protective. And what is cognitive reserve? It's a broad concept which could be responsible for reduced susceptibility to impairment due to individual characteristics like genetics, increased synaptic or neuronal capacity, greater efficiency in the brain capacity to use alternate strategies. So even if somebody is carrying the gene for AD or FTD or whatever these degenerative disorders, they may be functionally much better if their cognitive reserve is better. Cognitive reserve is earned by using. So what are the mechanisms of homeostasis in the normal brain? These are the ones which are accentuated by neuroprotective agents. So brain is a very mysterious organ, and our inability to understand its physiology and chemistry is important, but it is not, but even a small fraction we do not know. Because it is very strange. We study our heart with the brain, we study our kidney with the brain, we study with our intestines with the brain, but with what organ we are studying the brain? We are trying to study the brain with the brain only. So it is a very strange situation. There is role of epigenetic factors, micronutrients, and plasticity, all important in maintaining the homeostasis so that the brain functions normally till the one Purusha year. So what is this plasticity? That is the capacity of the nervous system to modify itself functionally and structurally in response to injury. And it happens by, and there are excitotoxins, glutamate toxicity, NMDA toxicity, they are excitotoxins. So these protective drugs and the repair mechanisms utilize this efficiency, and they have anti-excitotoxic effects. Apoptosis inhibitors. We saw what is apoptosis. That is apoptosis inhibitors. Anti-inflammatory. Inflammation and infections are one secondary factors in aging. So anti-inflammatory properties. Iron chelator. Iron is an oxidative poison. So iron chelating. And use of stimulants when there is degeneration, stimulation. And gene therapy and stem cell therapy are based on utilization of the plastic mechanisms. So plasticity can be described at the level of the cells, at the level of various molecules inside the cells and connected. So it can be one cell, one molecule or the network. And so the possible agents which improve plasticity are growth and neurotrophic factors, antibodies. We know that these things are not now commonly used. Gene transfer, antioxidants, hypoxic ischemic neonatal inflammatory mediator modulators, excitatory amino acid agonists and antagonists, free radical scavenger, and various other factors which antagonize aging process. Then glutamate receptor antagonists, substances which target specific intracellular pathways, neuromodulators, neurotransmitters, G-protein coupled receptor activation. Then you have got some neuroprotective effect of anesthetic agents. So all these are possible agents which work as neuroprotectors. And there is something called brain cocktail. What is this brain cocktail? It consists of a mixture of free radical scavengers, drugs which enhance nitric oxide activity, metabolic inhibitors, calcium and iron chelators, and all this put together is called a brain cocktail. And compounds that may inhibit CNS necrosis or apoptosis, anti-inflammatory cascade promoting agents, that is progestational and other steroids, and pharmacological candidates for neuroprotection involves erythropoietin, very commonly known to all of us, which is anti-apoptotic, antioxidant, anti-inflammatory, supports angiogenesis and revascularization. So these are the fundamental methods through which neuroprotection happens. So the term nootropics is the term utilized to describe the neuroprotective agent. These are not popular, but they are very, very useful if you put it into our practical use. Cornelius E. Georgia in 1972 introduced this term nootropic. They do not directly release. So important to understand how these neuroprotective agents act. Unlike if you take donepezil, it will act on the cholinergic enhancement, so neurotransmitter. Whereas nootropics, they do not directly release neurotransmitters or act as receptor ligands. They act by improving supply of glucose, oxygen, anti-hypoxic agents, and protecting neuraxis from neurotoxicity. So they enhance the nutrition for the nervous system and protect from neurotoxicity. And they positively affect neuronal proteins, nucleic acid synthesis, and stimulate phospholipid metabolism. They eliminate free radicals. They have anti-aggregation effect and improve the rheological properties and plasticity. What is rheological property? Plasticity I defined. I did not tell about rheological property. As we know that the diameter of a red blood cell, which carries nutrition to the whole body, is about 7.2 microns. But the smallest intracranial capillary is 1 micron. So how can a 7.2 micron RBC carry nutrition to the terminal arteriole? That is by a property called rheology, where the RBC structures like a snake and manipulates itself. So during disease states, these rheological properties are lost, so that an RBC which carries oxygen can produce multiple infarcts, because it can block 7 capillaries. One RBC can block 7 capillaries. So these neuroprotective agents act on the rheological properties and enhance the flexibility of the red blood cell or the oxygen carrier. So these nootropic agents are called smart drugs. Nous in Greek means mind, and tropin means modifier. So it is they are classified as 2 groups. One is the naturally occurring neuroprotective compounds, and second is the laboratory created neuroprotective compounds. They are a heterogeneous group of drugs, and they are used in all types of conditions, acute, subacute, and chronic conditions, and they are well tolerated. So we will start from what was practiced in ancient India, and we will reach the newer methods. So Ayurveda science is a life-sustaining natural science, and they did not use the main aim of Ayurvedic science is to promote health rather than treat disease. So promotion of health is ancient Indian principle of maintaining health, and Atharva Veda is based on the idea of balance in bodily systems, uses diets, herbal treatment, and yogic breathing. And Ayurveda is a natural system of medicine originated in India 3000 years ago. The term Ayurveda is derived from the Sanskrit word Ayur, means life, and Veda means science of knowledge. So we'll start in that order of utilization of these medications, which are the neuroprotective agents. First, Brahmi is a wonder herb known to stimulate memory and cognitive ability. It is also having role in behavioral alteration and prevent oxidative damage, contains powerful antioxidants, reduce inflammation, boosts brain function, helps to reduce ADHD symptoms, prevents anxiety and stress, and it lowers blood pressure and has anti-cancer properties, and it is used in 2 to 3 grams of Brahmi along with meal. Next is the curcuminoid and the black pepper. Turmeric can increase the antioxidant capacity of the body. It is anti-inflammatory, antioxidant, and boosts the brain-derived neurotrophic factors, improves endothelial function, and useful in managing depression, aging, and Alzheimer's disease. And it has been used in India for thousands of years as both a spice and a medicinal herb. And now this active compound curcumin is one of the newest agents used in management of Alzheimer's disease. And ashwagandha, Brahmi and ashwagandha can be taken together. This is used in ancient India from Charaga's time, and it boosts the brain activity and together maintain healthy function of the brain. And these drugs have mild side effects on the GI tract only because they are naturally occurring compounds. And another drug is the tartaric acid, which is the tamarind, which we commonly use in all the cooking materials. So now we will come to the newer agents and how they act. So ancient India itself practiced neuroprotection because Ayurveda is health promotion, not disease management. It is health promotion. Now we will come to L-carnosine. It's a dipeptide made up of beta-alanine and histidine. These are the two active compounds in L-carnosine. It scavenges both reactive oxygen species. We saw about how apoptosis acts by enhancing oxidative stress. So this reactive oxygen is what? It is an oxygen which contains an incomplete outer ring. Because of the incomplete outer ring, it is a spinning molecule. And when it spins, it does not supply oxygen to the tissue. Instead, it spins and destroys the tissue. So that is the reactive oxygen. Whereas the nutritional oxygen is what benefits. Reactive oxygen destroys. So this L-carnosine destroys the reactive oxygen species. And the unsaturated aldehydes produced by the membrane liquid peroxidation. When there is reactive oxygen spinning there, instead of restfully supplying oxygen, it is spinning there. So it destroys the lipid peroxidase membrane and releases another kind of toxin, that is unsaturated aldehydes. Those are all scavenged by L-carnosine and reduces the rate of formation of advanced glycation end products. That is more common in diabetics. When they have got insulin deficiency, the advanced glycation end products, which are toxins, are produced in diabetes. That is producing the damage the nervous system and other systems from brain to the peripheral nerves. So those things are all removed by L-carnosine and protects against oxidative damage and chelates toxic metals like iron. And this is the L-carnosine molecule C9H14N4O3. And carnosine is a dipeptide molecule made up of the amino acid alanine and histidine. It is concentrated in muscle and brain tissue, and it was described for use by the Russian chemist Vladimir Gulevich. And carnosine is naturally produced by the body in the liver from alanine and histidine. reducing this reduces the buildup of amyloid beta. We know that amyloid beta accumulates in every brain as we age, but when the amount of amyloid beta is much more due to the genes which are present which promote rapid apoptosis, presenilin 1 and 2. This presenilin 1 and 2 are involved in Alzheimer's mechanism where the amyloid plaque formation is too much, and this L-carnosine prevents the buildup of amyloid in the brain. And it is an antioxidant, favorably affects energy and calcium metabolism and reduces lactate accumulation. We know that lactate and pyruvate indicate mitochondrial dysfunction, and I have described in the apoptotic mechanism how mitochondria and cytochrome C are getting damaged when we age. So this prevents this lactate accumulation, and minor side effects only when some people can get some stomach upset, headache, nausea, and vomiting. So can happen. So we will see the action because it is made of beta-alanine and dimethyl histidine. They are the active components present in L-carnosine. It is anti-inflammatory and quenches the reactive carbonyl acrolein. So apart from the antioxidative, mitochondrial protective, preventing lipid peroxidation end products, preventing amyloid accumulation, it is having anti-inflammatory property by quenching the reactive carbonyl acrolein, and it regulates macrophage function. Macrophage function is important for our immune mechanism, so it enhances immune mechanism and scavenges both reactive oxygen species and unsaturated aldehydes produced by cell membrane lipid production, reduces the rate of formation of advanced glycation products and protects against oxidative reagents and chelates toxic metals. So these are the, so in the brain, L-carnosine acts on oligodendroglial cell, the neuron as well as the astrocyte supporting cells and the neuron, all the cells L-carnosine is acting, and it protects by all these mechanisms which I will be elaborating in another slide. So it gives, apart from all the things which have been well documented and studied, and it has metabolic support to the neurons, pH buffering. When there is acidosis, the cell will die. So L-carnosine will buffer that acidosis and make it friendly for the neurons. And anti-inflammatory cytokines. We know that there are pro-inflammatory and anti-inflammatory cytokines, which are mediators, whereas pro-inflammatory cytokines are leading on to apoptosis. Anti-inflammatory cytokines are protective. So L-carnosine will promote anti-inflammatory cytokines. It limits the zinc and copper related toxicity and carbamylation related toxicity. Free radical scavenging, N-methyl D-aspartate toxicity, that's an excitotoxicity, that is also removed. And it promotes brain-derived neurotrophic factors and nerve growth factors and modulates neurotransmitters. Even though it does not produce a neurotransmitter or does not enhance the level of neurotransmitters, it modulates the function of neurotransmitters. And beta-alanine and L-histidine are its active components. So what are they? We will see one by one. Alanine is a non-essential amino acid in protein synthesis and glucose metabolism. It acts as an inhibitory neurotransmitter in the brain, and it is produced from pyruvate transamination in the Krebs cycle. And it helps break down tryptophan and vitamin B6. And its requirement per day is about 20 to 40 grams per day. And when we give beta-alanine supplements, it buffers the acids in the body, so it becomes energetic, and it is having antioxidant effect, and it will help the muscles to move on, and it enhances the action of caffeine, and caffeine is a stimulant, so it has a multiple roles so that it will improve the cognitive and motor functions. Sometimes people report some paresthesia, the cause is not clearly known, but it appears that beta-alanine can function sometimes as a neurotransmitter, like a molecular mimicry. It doesn't produce a neurotransmitter, but it can act like a neurotransmitter. And beta-alanine is a structural analog of GABA, gamma aminobutyric acid, and glycine, which are the major inhibitory neurotransmitters in the brain. And it can react with these receptors. So that is called molecular mimicry. So you imitate a natural receptor and act on that and produce a different function. Like we're putting on a mask and acting like another country person and getting entry into that country. So we can act on the GABA and glycine receptor by mimicking those neurotransmitters. And AG protein coupled receptor from the MRGD family has been identified in the sensory neurons of the dorsal ganglia. And beta-alanine interacts with this receptor. That may be the mechanism by which a transient paresthesias may be experienced with the beta-alanine component of L-carnosine. But this property is exploited in management. So this gives another use in management of pain also. We see the counter irritant. So it can have a counter irritant action in some situations with the pain. So beta-alanine, which is the main one of the main component in L-carnosine, is anti-fatigue, anti-pain. I explained the mechanism, how it interacts with the neuroreceptors of glutamate, GABA, and dorsal root ganglia. So it can act as a counter irritant and helpful in pain management, anti-glycation in diabetic, anti-glycation end products in diabetic, and anti-crosslink. What is crosslink? Neuronal crosstalk, we know. Supposing a cardiologist or a neurologist goes to the cardiology OP, which happens in rural medical colleges, sometimes when outbreak of disease is there, all super specialists will go to one team. But you know only that. So there's a cross-link. A cardiologist come to the neurology OP, he might ask about cardiac symptoms. Whereas a neurologist going to the cardiac OP, he may ask about the neurological symptoms. So that is called crosstalk. When one fiber carrying one function talks to another fiber, that function responds with another aberrant function of the neuron that is talking. This results in paresthesia, dysesthesia, hyperalgesia. So those symptoms are inhibited by beta-alanine. And it chelates acids. It produces pH balance, has antioxidant property and anti-stress property, and possible protective role in prion disease, which is a terrible infectious, rapidly progressive dementia. So probably this can have a role in the treatment of prion disease, which at present does not have any major treatment options. And ischemia-induced neurotoxicity and Alzheimer's disease. That is the first component of L-carnosine. What is the second component also we'll see. So this beta-alanine acts through the various mechanisms we have gone through, and it protects the brain, protects the nerves, and protects the peripheral nerves also. So you have got several beneficial effects on the muscles. It reduces fat mass, enhances anaerobic capacity, and increases the power output, and increases the lean muscle mass, and reduces the fatigue. So these are the various benefits of the beta-alanine component of the L-carnosine. And then it will be very useful in physical, because it enhances the function of the muscle. It is very useful in people who are engaged in active sports, and it prevents the buildup of acidic pH. So like that, it increases muscle carnosine. So even in neuromuscular diseases, this can be tried. So how this is generated from the Krebs cycle, which I mentioned, is shown in this cycle. This all of us have studied in biochemistry. We can check the Krebs cycle. Next component in L-carnosine is histidine. Histidine is used in the production of myelin sheath. All of us know that the nerve cells, nerve fibers have an insulation material that is called myelin. And this supports and protects the neurons and the nerve fibers. And L-histidine is used in the production of myelin. That way it is protective and it is having antioxidant property like beta alanine, and it is having effect on the digestive system and joints and anti-inflammatory properties. So it is seen in the brain. It is seen in the histidine is useful for the brain, muscles, heart, and GI tract by various receptors. Histidine acts through 4 receptors, H1, H2, H3, H4, and each receptor is taking care of functions of the nervous system, muscles, heart, and intestine. And based on the receptor in which it acts, it is having a multidisciplinary protective role. And the dosage in children is about 800 milligram per day in 2 divided doses. I think the children's part I have not elaborated in this study, even though I myself have a personal experience, because the talk was done by Professor Mary I. I omitted that part in this presentation. I will give some recent examples also, my direct experience. So the dose in children is 800 milligram per day in 2 divided doses. In an adult, it is 1.5 to 2 grams a day. And it takes about 8 weeks to see the effects. And duration of therapy is not very well defined. So we have got beta alanine and L-histidine, which are the active component of L-carnosine. And this beta alanine and histidine, when it is acted upon by carnosine synthase, L-carnosine is produced in the body. And its benefits is on the brain, on the heart, and on the digestive system, protective for postpones the onset of cataract. All these are by antioxidative effect, and it is having effect on cancer and intestinal functions. So now this is another method how this alanine and histidine together produces various methods by which free radicals are scavenged, beneficial nucleic acids are enhanced, and neuromodulatory function is taking place. That is the metabolic breakdown pathway in the system by which neuroprotective actions are produced. So in children, it is indicated for autism. It is really very, very beneficial. I have a large number of children from Bangalore days to Trivandrum, and language skills along with the therapy speed up the communicative skills of the children. But I am sure this was dealt with during the talk of Professor Mary I. It improves language, auditory processing, socialization, motor planning, and awareness of surroundings so that they can interact. Autism spectrum children do not interact. All these parameters improve, and it prevents and treats attention deficit hyperactivity. And also it is useful in complications of diabetes. As we saw, the advanced glycation products are prevented, and amyloid load is reduced. So Alzheimer's disease, liver and kidney problems, and vascular diseases, because it enhances the level of nitric oxide and it improves the rheological properties of RBC. I explained nitric oxide is a vasodilator. RBC is 7.2 micron and intracranial capillary is 1 micron. So when the rheological property is increased, the rigid RBCs are able to carry oxygen to the terminal capillaries. So that way it is useful in vascular diseases. So I will elaborate one recent case. This person, I saw him in December 2022. He was treated for about a week in another hospital for a massive stroke, because this person had a posterior cerebral artery which was having an anomalous supply to both sides of the brain. Normally, posterior cerebral artery supplies the occipital lobe. In this patient, a single posterior cerebral artery. Unfortunately, instead of 2 posterior cerebral artery as a congenital anomaly, he had a single posterior cerebral artery, and this posterior cerebral artery had an extended supply to both the temporal lobe, brainstem, apart from the occipital lobe. Because of that, this person was having hemianopia, and he was paralyzed, confused, he could not swallow, and he had because both temporal lobes were gone, he could not communicate, he could not comprehend. He was on Riles tube and he was almost dying when I received him from another hospital. So I started him on day one itself because it was beyond the time of any thrombolysis or any other mechanisms of management. I started him on full dose of L-carnosine from day one of my getting him. And this is the occipital, this is a classical PCA territory which gets infarcted, but this person had an anomalous PCA. Because of that, it supplied more area. So this is the PCA territory, and these are the extended areas that were self-supplied in this patient. Both temporal lobes and cerebellum were also supplied. So he had a massive stroke. He had an anomalous artery which was supplying more than its usual territory. So this was a very fatal stroke, and we told him that his chance of survival is very, very poor. But this is how he looks now in February. So that was 2022 December. Now he is ambulant. He is remembering many things, and he is functional. He is continent. He can swallow, but he has a right homonymous hemianopia. That alone is remaining. So this is 2 weeks into full dose of L-carnosine in an acute stroke which was beyond the time window. These are recent cases, old cases, pictures I have to trace, but I have them, but I could not do that because of the time constraint. And this is another person. When they are very acutely ill, because of the faith prevailing, they don't allow us to take photos. So we cannot take photo when they are critically ill because they believe taking photo is a fatal thing. It will improve, worsen fatality. So this is another patient who came like this. Decorticate. Decorticate means brainstem is, the damage is disconnecting the brainstem from the cortex. So this was the posture in which we received this person. And he had a massive cerebellar infarct. This was also bihemispheric cerebellar infarct, which was compressing the brainstem. And now this is how he looks now. Exactly, these two patients came in December, and unimaginable recovery happened. In many patients, it happened. Even late in the course, it happened. But these are the latest examples I have seen after I retired. So minor side effects I have already mentioned. So AD in Alzheimer's patients, we had a study done. That gist I will tell. The whole data has not been analyzed so far. Still, I can tell the gist. So, what is the situation where I use AD patients with L-carnosine generally is cardiac patients, because we know that cholinergic agents which are commonly used in the management of Alzheimer's disease are cardiotoxic. They produce cardiac arrhythmias. Apart from GI tract side effects, major GI tract side effects are there. So those patients I generally use. The cost is a limiting factor of prescribing these medicines to everybody. So I use it commonly in patients with heart disease, where L-carnosine is cardioprotective, whereas donepezil and other cholinergic enhancers have cardiotoxicity. And patients do show behavioral improvement at the end of 6 months. I use it for an extended period of time because this is a progressive disease. Those who can afford, I tell them to continue. And by the end of 6 months, considerable improvement in the behavioral management problems is seen in most of the patients, because most important thing which affects the caregiver is the behavior more than the memory problem. In senior citizens, people don't mind if their memory is not so good, but the difficult behaviors are the ones which are very troublesome to the caregivers. By 6 months, significant improvement in behavior is seen in all these patients, and it decreases the beta amyloid, which we saw beta amyloid accumulation, and A beta 1 and 42 induced toxicity in microglial cells is antagonized, and it counteracts on oxidative stress and inflammatory status. We know that now there is an inflammatory hypothesis based on which the immunomodulators are tried in this degenerative disease, and that action is already there in L-carnosine, And AB oligomers promote neuroinflammation and neurodegeneration. And L-carnosine acts through the anti-inflammatory cytokines or interleukin-10. And that way it reduces the level of inflammation and its consequences. And slowing of progression is definitely seen. These people definitely progress if you longitudinally follow them up. I have now about from 2016 onwards, I have started using. So long-term follow-up is there, but the disease certainly progresses. But the progression is very much less in those people who are able to afford this medicine for a continued use. So we did an unpublished study on 100 patients with 100. We used 100 patients in the test group and 100 controls from 2017 to 19 at Nimhans. There were 25 AD patients, 25 FTD patients, and 50 vascular patients. And we analyzed independent status examination, everyday activity scale, and MOCA, and comorbidity and habits duration were all assessed, and they matched the candidates were only included in the study. And we followed up these patients for 6 months to 2 years. And we found that this is my personal study helped by Sri Jyoti Kumar by supplying lot of samples. And so L-carnosine, we found it is most effective in patients with vascular cognitive decline than the degenerative ones. And it works most in patients with dominant hemispheric disease because it had language functions improved very much in many of these patients, and brainstem functions improved in patients with posterior circulation stroke. So it was very, very useful in patients with dominant hemisphere disease and posterior circulation disease. And it is useful even if it is started late, as late as 6 months after the event. We have included these patients not in the acute phase, unlike the 2 examples I showed. In our study, we used the late patients who were on follow-up and outpatient management only. None of them were inpatient. The 2 examples I showed are inpatients. And it is also showing significant change in language. And treated AD patients had better ABC. ABC means activities of daily living, behavior, and cognition. So treated AD patients had better ABCs than the conventional patients at the end of 1 year. It was definitely there. But they progressed because, as I said, from 2016, I started using. So now I have patients with about 7 years progression follow-up. So they progress, they do progress, but there is a difference. And FTD, that is a frontotemporal dementia patients, did not show any appreciable change in our 2-year follow-up study conducted at Nimhans. And our data is not yet published. It is on a series of 100 persons with dementia. And as I said, other parameters, like unlike language and posterior fossa functions, there was considerable, and ABC functions, there was considerable improvement in apathy, executive function, and memory in patients with vascular dementia. Vascular dementia patients are the ones who benefited most in this group. And in stroke patients, improvement in language and balance was seen even 6 months after the insult. And children with autism spectrum disorder showed considerable improvement in behavior and cognitive skills. So next drug, so L-carnosine is over. The next drug I am familiar and I use 3 drugs in this group. One is L-carnosine, second is nicergolin, and third is piracetam. And nicergolin is an ergot alkaloid. It protects cultured neurons from beta amyloid, and it improves the nerve growth factor. It is useful in various types of diseases affecting cognition. It's a vasodilator, improves glucose utilization and antioxidant. And personal experience, I find it very useful in the management of atypical Parkinson's disease. Atypical Parkinson's disease patients are not usually responsive like the idiopathic Parkinson's to the DOPA group of drugs. So these people show very good improvement with nicergolin. Piracetam, this also I am familiar. L-carnosine, nicergolin, and piracetam I regularly use. It's a derivative of gamma aminobutyric acid. It improves the function of the neurotransmitter acetylcholine through the muscarinic cholinergic receptors. Its effect on NMDA glutamate receptor, which is an excitotoxin, improves learning and memory. And it is used in 1.2 to 4.8 grams daily for cognition and memory. For dyslexia, 3.3 grams. And mental disorders, 2.4 to 4.8 grams. And myoclonic seizures, 7.2 to 24 grams. And its advanced derivative is the brivaracetam. Now it is very actively promoted in the management of seizures. So it's a derivative of piracetam. But piracetam is used in all these conditions and it is extremely useful. I have experience with this drug from my student days. My teacher used to use and I continue to use. It's a very wonderful drug. And it acts on calcium ion channels, enhances acetylcholine via muscarinic receptor. ATP is favorably influenced. ATP, adenosine triphosphate, is enhanced. Improves electron transport in mitochondria via cytochrome pathway, and it is well tolerated except mild drowsiness. There is not much side effect. And piracetam has effect in the vascular system by reducing erythrocyte adhesion to the vascular endothelium, hindering vasospasm, and facilitates microcirculation. And I have a vast experience with this drug from my student period over 3 decades and yields excellent results in strokes. However, somehow it's a large data. Maybe it will run to several thousand patients, but I unfortunately did not enter these patients in the Excel sheet or analyze the data. It's an experience-based presentation rather than I have not done but I am very, very convinced that it is a very useful drug. Next is citicoline. I don't have primary experience on this. It stabilizes cell membrane by increasing phosphatidylcholine and sphingomyelin synthesis. It is intermediary in the biosynthesis of phosphatidylcholine and stimulates the biosynthesis of structural phospholipids of the neuronal membrane. It preserves the neuronal energy reserve, inhibits apoptosis, and stimulates synthesis of acetylcholine. It is also claimed to increase blood flow and oxygen consumption in the brain. And it is used in varying doses, but usual dose is about 500 to 1000 milligram by mouth twice daily for up to 12 months. And edaveron is a drug which is promoted now apart from strokes in the management of amyotrophic lateral sclerosis, motor neuron disease. However, I have tried this in patients with motor neuron disease. It is little expensive. I have tried giving the full course, but unfortunately, I did not find even one patient improve. Even though the literature recommends its use in ALS, I have not seen improvement in my personal experience in about from Nimhans days. So far, I would have tried in about 13 to 14 patients with motor neuron disease. None of them improved. Ginseng, everybody uses, but I have not used it. It improves nitric oxide. It increases the activity of superoxide dismutase. Superoxide dismutase is an oxygen free radical scavenger. Endogenously occurring free radical scavenger is enhanced and it improves physical and mental resilience and used 120 to 300 milligram per day. Other drugs in this series are vinpocetine, pyretinol, naptidrofuryl, dihydroergotamine, phosphatidylcholine, vitamin C, and other alpha tocopherol and caffeine. I have not used these agents as a medicinal one other than vitamin E. So I have ultimate neuroprotection comes from something else. So that is a philosophy of aging. So one's main purpose in human life should be to purify existence and achieve liberation. So I used any medication for my patients only if I am convinced that it will help. Otherwise, I don't write or I don't use. The 3 drugs I said, niacin, L-carnosine, and piracetam, I have personal experience, they help. That's the only reason I use them. And so that will also reflect the philosophy of life. One's main purpose in human life should be to purify our existence by reducing the suffering of fellow human beings to the extent possible. And in this material world, to render service to the lotus feet of the Lord is who is the cause of all causes, and to see him everywhere is the motive. So you see the God in your patients, and I see the God in my patients, and I treat them with the gods as my witness, nobody else. And gross material science cannot divert the real purpose of human life. They can only increase the artificial needs of life without any solution to the problems of life. So everything should be done with complete surrender. Then only even these neuroprotective agents will work. You have to do it with the complete surrender. So human life is meant for reviving one's eternal relationship with the Lord, and all Daridra Narayana and Narayana we say. So you have to treat the Daridra Narayana whom we are going to meet, so that we will attain the lotus feet of Narayana. And neuroprotection in daily life, most important. If you don't want to lose, you have to use. So every body part should be used if you don't want to lose them. You have to do physical exercise, mental exercise, read, intellectual activities are very much important if you don't want to lose. So use if you don't want to lose. Whatever thing you don't want to lose, is it your memory or is it your body parts? Use them so that you don't lose them, and don't rest if you don't want to rest. After retirement, I want to rest, or I have worked for 15 years, I want to rest. If you rest, you will rest. And nerves have to fire, to wire. I told about the plasticity which acts at the level of molecule, at the cells and connections. So connectivity is very important so that there is a homeostatic function. Nerves should fire to wire. That happens only by activation. Be vegetarian. We know that our system is a vegetarian system, and vegetarian food digests by fermentation like process. All the products are nutrients, and you have to reduce the sugars, salty food, alcohol, processed meat, organ meat, shellfish, beer. All these things should be reduced, stopped totally. And Alzheimer's disease results, even though you may have the presenilin 1, 2, all those things, it probably is from a maladaptation to an evolutionary pathway which happens with this type of diet. So this type of diet, epigenetic mechanisms, you may carry the gene, you will never know. The patients will tell, nobody in my family got. Maybe they had a very healthy lifestyle. So the epigenetic mechanisms protected them. So this kind of diet is protective even if you are prone for the degenerative diseases. And plant-based whole foods are the best. Exercise and use photomodulation, ultrasound therapy. They are all other various type of neuroprotective therapies which are used in disease states. Avoid foods containing monosodium glutamate, artificial taste makers seen in some of the foods like Lays, noodles. So these are actually used as an animal model to produce. Monosodium glutamate is the animal model, mouse model for Alzheimer's disease in Nimhans research. Mouse research is going on where monosodium glutamate is used to produce Alzheimer's disease. So Mediterranean diet is recommended. What is this diet? It is a way of eating based on the tradition of the people who live around the Mediterranean Sea. That is the Spain, France, Italy, and Greece. And this is mainly containing healthy fats, fruits, vegetables, nuts, seeds, legumes, and whole grains. And so this is called Mediterranean diet. This is supposed to be protective, provided we start it very early, and maintain proper weight by following a healthy diet. Exercise regularly as it helps in less cognitive decline and brain protection. Avoid smoking and alcohol. If alcohol and smoke is banned from the world, 50% of the hospitals can be closed. And avoid stress by practicing meditation or yoga. Include fruits and vegetables in your diet as they contain antioxidants. Eat nutritious food as it helps in cognitive stimulation, and mainly fruits, vegetables. And like limit foods with high cholesterol and saturated fats, cut down on sugar, salt, and processed food, follow a healthy lifestyle as it helps in improving overall health and possibly protects the brain. And do not take alcohol, smoke, or other substances. Wear helmet to avoid head injury. Post-traumatic dementia is one very, very common cause for cognitive decline. Avoid HIV, VDRL related disorders. Take care to treat ENT, dental, and other systemic infections. It has been, as I said, inflammation is supposed to be one cause for dementia. It can be in any part of the brain and affect the neuroaxis. And treat diabetes, hypertension, heart disease, asthma, and dyslipidemia properly. Take fiber and vitamin-rich balanced diet with vegetables and fruits. And exercise, remain active, keep learning. Discussing my teacher, Professor K. Srinivasan, Madurai, he used to tell that when we got the DM degree, he told me, you are given degree not because you have learned anything. We think you are capable of learning. That is what he told. And he has told minimum 4 hours of reading is mandatory. That I practice throughout my active days. Now I have reduced it a little. Still I read every day. Even if it is very late, I read. So that our brain remains active. And cultivate the habit of positive thinking. And then engage in extracurricular activities like music, yoga, crossword puzzles, reading and writing. And can use dietary supplements when needed, blood thinners if your physician feel is indicated for you. Consult your doctor when you find anything going out of place, like activities of daily living, decision making, sleep, personality, and communication skills. When you find it is declining, immediately see your doctor. And this is a book which I wrote on. This is the first Indian complete book on human cognition, only containing Indian data. Most important, it's not a Western data, it is only Indian data. So now ultimately, you improve the disability adjusted life years, DALI. We can live up to 120 years, and that life should have good quality. So we went through the neuroprotective mechanisms which improve the DALI, but the ultimate purpose is to find out your real nature. That is beyond, that is the ultimate protection. Thank you. I finished.
Thank you so much, ma'am. Thank you, ma'am, for your exhaustive talk. And it really is an insight on the role of a neuroprotective agents in patients with vascular, non-vascular cognitive decline. And it was, it's really a great insights. And there are 2 questions in the chat box. Can we take it, madam?
Yes.
Yes. The query is that they want to, one of the doctor want to know how long L-carnosine to be given in post-stroke aphasia.
Actually, there are no definite recommendation, but the improvement starts by about 8 weeks. You have to wait at least for 8 weeks to know whether it is helping. And I have used it for more than 6 months.
Okay.
Without any side effects. Definite recommendations are not there in the literature. It is saying that about 3 months. When I went through literature, it is saying some 3 months, but I have used up to 6 months, and I have seen very, very good results. And I did not see any side effects. So I think if the person can afford, they can take it for at least 6 months without any major complications.
Thank you, ma'am. That were the query many doctors have been asking. Here also on fat box testing. And how is that, one of the doctor wants to know, what's your clinical experience on NMD-induced neurotoxicity?
You
and
see,
what are those you recommend?
NMDA-induced neurotoxicity is very, very well seen in our patients with autoimmune encephalitis.
Yes.
It is an acute condition. In chronic condition, most of the neurodegenerative diseases share NMDA excitotoxicity, including FTD, AD, CJD. All these conditions have NMDA-induced excitotoxicity in a slow pace. But all of us are very familiar with the acute NMDA excitotoxicity, in which I have published a large series. Several papers I have published. They present with acute encephalopathy with chorea, seizures, dementia, then severe psychosis, catatonia. It's an acute presentation commonly seen in children with or without ovarian tumors or testicular tumors. So it can be a paraneoplastic syndrome or non-paraneoplastic NMDA excitotoxicity presents with a acute or subacute course, very stormy presentation, and they need immunosuppression treatment, and always screen them for tumors for at least 2 years. So that is acute NMDA toxicity syndromes. In this area, I have published 7-8 papers, my experience, and I have also described a triad which is called Chandra's triad for describing, for clinically suspecting, because most of these patients are considered psychiatric illness, because thinking that way valuable time is lost. Acute NMDA syndrome or acute VGKC syndromes have a lot of behavioral problems. So they are suspected as psychosis and they are treated with antipsychotics, and valuable time is lost. So I have described a triad of unusual panic, other than hallucination and delusion, severe fear like rabies, unusual panic, sleepiness with catatonia or myoclonus. So this is the triad: panic, sleepiness, and sleepiness is not commonly a feature of psychosis until we treat them. They are very active, aggressive, running down, destroying. Whereas NMDA you suspect when they are sleepy. So severe panic, sleepy with catatonia or movement disorders, other movement disorder. This is the triad I have described. If you see it, you must order NMDA VGKC panel, because it is a life-saving treatment option with complete cure is there. So that is acute NMDA toxicity. Chronic NMDA toxicity is there in most of the degenerative disorders.
So you have got a good experience with L-carnosine also, madam, in this condition?
Now, in the L-carnosine, I have in the acute NMDA, all these chronic dementias are chronic NMDA toxicity is a factor, one of the factors. So those patients only I described. In acute patients also, I definitely tried. After they come out of the immediate situation, you have to treat them with steroids, plasmapheresis, or rituximab. That has to be given, and it is given for about 6 months to 2 years, depending on the rate of recovery of the patient. And once they recover, they have cognitive sequelae. That L-carnosine is very much useful. But I have not started it in the acute phase in my patients, because in the acute phase they are so sick, they are put on other treatment options. When they settle down, I have tried it and it helps.
I still vividly recall, ma'am, you have revived one young girl, Priya, called 19-year-old girl, whom
Not
you
one,
described.
many patients I have published.
It was
all there in the PubMed. All PubMed series I have published in.
It was in Nimhans, because the father of the patient came and gifted Vignesh idol. I still vividly remember. Thanks, ma'am. Your involvement on patient cure is something. It goes beyond any descriptions. And thanks for your wonderful deliberation. Thanks for your
Sir,
time.
we have 2 more
And
questions, sir.
Yeah, please.
One question is, in Alzheimer's, reversible with the supplementation of L-carnosine? If yes, what's the dosage and how long it has to be taken?
Sir, it is not reversible. As I have told, L-carnosine in Alzheimer's is ideal in situations where the patient's donepezil is not indicated when they have heart disease, because it's a cardiotoxic, donepezil produces cardiac arrhythmias. So there I regularly start with L-carnosine. It is used as 2 tablets twice daily, and that by 6 months there is a definite matched improvement. I have narrated the 100 versus 100, of which 25 AD and 25 L-carnosine group and 25 conventional group. You have compared all parameters. The data is unpublished data. It is there with us. We have to do little statistics on that. But these patients, definitely by the end of 6 months, were much better controllable in their activities of daily living. Those who were incontinent became continent. Their bowel bladder symptom, that's one of the most troublesome symptoms. They are not passing urine and motion in wrong places. That is one parameter which improved. Difficult behavior, aggression, running out of the house, that things improved. And cognitive capacity also improved, so that some small communication can be engaged with them, so that everyday activity score, which I have told that HMSC everyday activity score and MOCA we had applied in these patients, and everyday activity score definitely showed that patients can be made to understand. Otherwise, we tell that communicating with the dementia patient is two people communicating with two different languages which they don't understand each other. I speak in Tamil and somebody, a Kannadiga patient is in front of me, both of us do not understand. That is the way we talk to a patient with dementia. They do not understand what we say and we do not understand what they say. These communication skills, that is called cognitive. A, B, C is, A is activity of daily living, where the most important troublesome symptom is the continence. That definitely improved at 6 months. Behavior becomes less difficult to manage, less troublesome, and cognitive communication improves. So the wife or the husband can tell their spouse, please understand, you have to help me by cut this vegetable, fold these clothes, and please sit in this place till I finish my cooking and come. So that kind of communication is better comprehended. That is called ABC score, that is evaluated through the EC. That's a recommended evaluation tool. We applied HMSC, EC, and MOCA in all the 100 patients we studied. These improved. But now, as I said, I have patients on follow for about 6 years. They have definitely deteriorated from their previous level. But the deterioration is much less compared to the patients who were on conventional medication. That is the difference. It doesn't cure. There is no cure for Alzheimer's as on date. And it should be started very early also. Very late, when the score falls below 10, don't treat. HMSC score less than 10 means nothing will work. They need not be treated. That is the recommendation. Okay.
Well, ma'am, thank you. And there is one more thing. Should neuroprotective agents be used prophylactically in apparently normal people, physiological aging after a certain age? If yes,
that is an unresolved question, and there is no literature on that. There is no literature recommending the use of neuroprotective agents in normal people, because then you have to control normal people with normal people. They should have comparable education, comparable genetic makeup, comparable potential for senescence. Then only you can conduct a study, because all of us, we have 120 years, but many of us die at 40. Some of us die at 60, 65, 70. It is variable. So normal volunteers have not been studied so far. So there is no clear recommendation at all, and I have not used it in normal people.